Hello students, in this session I will be talking about classification of fractures. I will try to simplify things for the better understanding. So what is fracture and why do we need classification? So classically, any breach in continuity of the bone is known as fracture. That means if you see any break here like this, that means there is a fracture. So the continuity of the bone has been breached. So whenever you are going for exam, always use this term breach in continuity whenever the examiner asks the question. So the breach can be like this or like this. That means even if the bone is perfectly aligned, but you see there is small break in the cortex which is not displaced, then also it is a fracture. And if it gets displaced, then also it's a fracture. So this is an undisplaced fracture while this is a displaced fracture. And why do we need classification? So that we can communicate the findings of the fracture. What is the nature of the fracture? What kind of pattern it is having? So that the communication is transferred to the other people in a standardized manner. And by that, the management of that particular fracture can be planned so that there is no confusion in the treatment plan. So the fracture can be classified according to various parameters. The first parameter is the location of the fracture. We all know that the bone is divided into three main regions: the epiphysis, the metaphysis, and the diaphysis. This is epiphysis, while this is metaphysis, and this is diaphysis, whole of the shaft of the bone. So fracture can be diaphyseal one like we see here. It can be metaphyseal one like this, and it can be metaphyseal with extension into the epiphyseal area, or you can say intra-articular fracture or articular fracture. Why? Because epiphyseal part always forms the joint, and the fracture line, whenever it enters the joint, it becomes the articular fracture. So the metaphyseal fractures can be extra-articular, that means fracture line is somewhere outside the joint, or they can be articular because the fracture line is going inside the joint. And always comment whether the fracture is in the proximal metaphysis or the distal metaphysis, because the bone is going to have the metaphysis and epiphysis on both the sides. And then we can classify the fracture according to etiology. That means what caused the fracture. So mostly the fractures are because of trauma. That means some road traffic accident, some fall, some injury has happened that resulted in fracture. But some fractures are pathological fractures. That means the bone quality is compromised. Therefore, because of the poor bone quality, minor trauma which should not result into a fracture or no trauma at all has resulted in a fracture. That means the bone quality is poor and the fracture has resulted because of the poor bone quality, not because of the injury. So those fractures are called pathological fractures. So the bone quality can be compromised whenever there is a tumor which could be benign or malignant. The benign tumor has to be contained inside the bone and should have clear margins, while the malignant tumor is more destructive. And other causes of pathological fractures are the infection of the bone, that means osteomyelitis. In osteomyelitis, which could be pyogenic, which can be tubercular, and sometimes fungal also, there is bone destruction. So because of the bone destruction, the bone has now become weak. Therefore, it is very fragile and is prone to fracture. And in some cases, the dense bone can also result in a fracture, like in cases of osteogenesis imperfecta and the osteopetrosis, and sometimes the bone forming drugs which patient consume like bisphosphonates. What they cause, they make the bone very brittle, that means very hard. And because of this hard brittle bone, the shock absorbing capacity of the bone is reduced. That means if there is sudden transmission of excessive force along the bone, it can fracture. While in normal bone, some part of the bone is soft, or you can say spongy in nature, which is usually meant for shock absorption. But that component is lost in cases when the bone becomes brittle. Other cause of pathological fracture in which the bone becomes very weak is the osteoporosis. Why? Because the osseous matrix formation is reduced in osteoporosis, and therefore it is prone to fracture even with trivial trauma. So these are the main causes of pathological fractures. And then what about the stress fracture? Stress fracture occurs in a normal bone, but the amount of stress on the bone is higher than the normal and is prolonged. Therefore, what happens? Because of this abnormal stress, the bone gets fractured. But here, the fracture is not a complete one. That means it is not a displaced fracture. Usually, it is an undisplaced fracture because of constant ongoing stress that result in microfractures. That means very small fractures which keep on healing on and on, while new fractures keep on generating on and on. These usually happen in athletes and in soldiers who have to stand for prolonged duration, do strenuous activities. And what happens? Because of the constant microfracture and constant healing, usually there is excess of bone formation at the fracture site. So therefore, whenever there is abnormal stress on a normal bone, it will result in a stress fracture. While whenever the bone is weak, and there is normal stress on that bone and it results in a fracture, that would be a pathological fracture. So there should not be any confusion in the pathological fracture and the stress fracture. So this is an example of stress fracture. You see, this has happened in an athlete who has to run every day. You see there is a fracture visible here. Fracture is a breach in continuity of the bone. As we can see here, this is a normal metatarsal, while this is the abnormal metatarsal in which there is a breach in continuity of the bone. And also you see there is prominence of the bone here, which is because of the new bone formation, because I've told you it happens because new bone form on and on. Now we can classify the fractures according to the pattern also. So this pattern is a transverse fracture. You see the fracture line here is transverse one, while this pattern is an oblique one. So this is an oblique fracture, while here you see it is S-shaped. So this is a spiral fracture because the fracture line assumes a spiral shape. So this is a spiral fracture, and it is very important to know what is the least energy trauma in these particular patterns. So spiral fracture is the low energy trauma compared to the other patterns. Then there can be a wedge fracture. Why? Because you see there is a wedge fragment, this one lying at the fracture site. So this is a wedge fracture. Then there can be comminuted or multi-fragmentary fractures. There you see there are multiple fragments at the fracture site, which is known as comminution. So this is a comminuted fracture. And while this is a segmental fracture. Why? Because there is a complete free segment of the bone at the fracture site. So you should be able to differentiate between the segmental fracture and the wedge fracture. In wedge fracture, you see there is a triangular wedge, while in case of segmental fracture, you will find a full cylindrical part of the bone that is lying at the fracture site. So that will mean that the fracture line are actually two and they are not in continuity. So here the fracture line is actually in continuity like this, but here there is a fracture line here and there is a fracture line here. So they are separate fracture lines. So that is important in segmental fractures. Then we can classify fracture according to displacement, as we have seen in the first example. So this is an undisplaced fracture, while this is a displaced fracture. We can further classify the displaced fractures according to the direction of displacement. So direction mainly includes the translation. That means the distal fragment can slide in this direction or in this direction. So that will be a translation. And then there can be angulation. Then the fracture can go laterally like this or medially like this. So that will be the angulation. Then the final component of the distal fragment displacement will be the rotation. That means the distal fragment can rotate in internal rotation or can rotate in external rotation. So these three components need to be addressed whenever we are telling about the displacement of fracture. That means what is the translation, what is the angulation, and what is the rotation. Then we can classify the fractures according to their open or closed nature. The fracture is called open when the fracture hematoma leaks out to the external environment, and in closed fracture the fracture hematoma remains contained and is not in continuity with the external environment. Also, it is very important to differentiate the open fractures from the fractures which are associated with wound. So if the patient is having a wound and a fracture, that doesn't mean that the fracture is an open one. The wound has to communicate to the fracture hematoma, only then it will be called as open fracture. Otherwise, you can call it a closed fracture with associated wound if it is not in continuity with the external environment. So you have to use the term fracture hematoma whenever you are defining the open fractures. Now the open fractures can occur from inside or can occur from outside. Whenever the fracture edge is sharp and it has resulted into the open wound, that will call as inside out. Why? Because the fracture fragment which was a part of inside has gone outside. This kind of injury will be inside out. But whenever there is an external object that is going inside the fracture to cause the open fracture, that will be known as outside in. It is very important to differentiate between these kind of fractures. Why? Because whenever the bone is coming out, the chances of contamination are lower compared to the external object going inside the fractures. Now the open fractures can be further classified according to Gustelow-Anderson classification. In Gustelow-Anderson classification, we need to be aware about four important things. First of all, the severity of the fracture pattern. So the spiral fracture and oblique fractures are considered as low energy trauma, while the wedge fractures and the transverse fracture are considered as medium or high energy trauma, while the comminuted fractures and the segmental fractures are considered as very high energy trauma. So this part is the energy of the trauma. Then the other parameter is the size of the open wound. After that, we have the amount of soft tissue injury. That means the skin, the subcutaneous tissue, the muscles inside the limb. What is the extent of their injury? We can classify them according to mild energy, then medium intensity injury, then the severe injury. These all things are subjective and the clinician has to make his own decision. The last important parameter is the contamination of the wound, whether the fracture is having minimal contamination, mild to moderate contamination, or severe contamination. That means the outside dirt that has gone at the fracture site. So type 1 is a low energy fracture, as I've already shown you in previous slide. and wound should be less than 1 centimeter, and there should be minimal contamination of the wound, and the soft tissue injury should be a mild one. So this should be the least severe open fracture. While in type 2, the energy is medium energy injury. That means the fracture can be a transverse one or a wedge fracture one, and the wound is around 1 to 10 centimeter, and soft tissue injury is moderate, and also the contamination of the wound is moderate. Always you need to see which component is having higher severity. That means suppose the wound is less than 1 centimeter but the soft tissue injury is moderate one, then also the fracture will be classified as open type 2, because we have to consider that particular parameter which is having higher severity. And suppose there is moderate contamination but again the wound is small and the fracture energy is low, then also it will be called as type 2. In type 3, the energy is high energy and the wound size is usually more than 10 centimeter, and the soft tissue injury is severe one. That means there can be associated compartment syndrome also, which is the highest grade of soft tissue injury, and there is heavy contamination. That means excess of dirt is there in the wound, and the gunshot, blast injuries and the farm contaminated injuries, they all are considered as type 3 injuries irrespective of any of this parameter. So suppose if the fracture is a comminuted one, or you can say segmental, but the wound is small, or you can say less than 1 centimeter, and the soft tissue injury doesn't appear to be much, then also it will be called as type 3, because I've told you the parameter which is the most severe one has to be counted. So if any of these parameters are found inside the fracture, then that means the fracture will be called as type 3 irrespective of any parameter which is having a lower severity. Now type 3 open fractures have subtypes also. In type 3A, the soft tissue coverage is preserved. That means it is repairable. While in 3B, the soft tissue is compromised to such an extent that it will need some flap. That means the plastic surgery team has to intervene to bring the soft tissue from some other location to cover the fracture site. That can be done by the flap. And type 3C injury is the injury which has associated vascular injury. So whatever the extent of injury of the other components, if it is associated with the vascular injury, then automatically it becomes type 3C. For example, if there are all components of type 2 injury but associated vascular injury, that means it will be called as type 3C irrespective of other parameters. I think it should be clear by now that the severe component has to be counted. Then there is another important aspect of fracture classification, the physeal injuries, which usually we see in the children who have the growth plate visible in their radiographs. So the classification of physeal injuries is known as Salter-Harris classification. There are some modifications that have been added after type 5 injury. So if we see this radiograph, you see this is metaphysis, this is the growth plate, or you can say physis, and this is the epiphysis which is towards the joint. So any fracture which is around the physis is counted as physeal injury. The type 1 physeal injury is the physeal separation, in which the fracture occurs directly through the physis and the epiphysis separates from the metaphysis. And in type 2 injury, the epiphysis separates along with a chunk of metaphysis. For your better understanding, just remember in type 1 and type 2, whole of the epiphysis is the part of fracture, while in case of type 3 and type 4, some part of the epiphysis is the component of the fracture. In type 3, there is epiphyseal fracture, but only some part of the epiphysis is fractured and there is no metaphyseal chunk, just like in type 1 in which there was no metaphyseal chunk. While in case of type 4, there is some part of epiphysis along with the metaphyseal chunk, just like in type 2 there was metaphyseal chunk. So this will help you in remembering this classification. In type 1 and type 2, there will be whole of the epiphysis involved, while in type 3 and type 4, some part of the epiphysis is involved. In type 2, there will be associated metaphyseal chunk, and in type 4 there will be associated metaphyseal chunk. And in type 5, there is compression injury of the physis and it is diagnosed retrospectively. That means injury has occurred, but the amount of damage that has been done is diagnosed after a few years of injury, because the growth becomes hampered and the limb becomes shortened. Because in X-ray we only see the physis, we are not able to tell what kind of damage has occurred to the physis. That will be diagnosed only after the damaged physis fails to grow properly and the patient will come with some deformity or shortening of the limb because the bone is not growing properly. Then there are some extra classification that have been added to the Salter-Harris classification. So in type 6 injury, there is injury to the perichondral physeal ring. That means injury to any part of the physis in the periphery. While in type 7, we have the injury to the epiphysis only. That means some part of the epiphysis is fractured which is away from the physis. And in case of type 8, there is a fracture in the metaphyseal area which is near to the physis. That means injury in this part can actually affect the physeal growth also. And in type 9, we have injury to the periosteum layer which is close to the physis. That means it is going to hamper the growth which is contributed by the periosteum in this particular part. That will result in abnormal thickness of this particular bone near the physis. This kind of injury will not be visible on X-ray, and it will be diagnosed only after few years of the injury when the thickness of the bone is abnormal in this particular part, because the periosteum contributes to the thickness of the bone while the physeal plate or the physis or the growth plate contributes to the length of the bone. So this is an example how you convey the classification. A 36-year-old patient with displaced transverse fracture of tibia and fibula at diaphysis or shaft, and which is open type 2 following a road traffic accident. Now you have told about the etiology of the injury, that is road traffic accident, the open type, whether it is open or closed, and you have further classified the open injury as well. Then the location of the fracture, that means the diaphysis, and the pattern of the fracture, that means a transverse fracture. So this should be adequate whenever you are communicating the information about the classification of fracture. Further classifications are also there. From your point of view, this much information is sufficient whenever you are communicating about the fracture classification.